brief background on what is pharmacogenetics. Even still in the US, most clinicians don't know what pharmacogenetics is, so I always start with just some brief background. I've abbreviated it as PGX throughout my slides. Then I'll go into some of the current clinical practice guidelines and recommendations for pharmacogenetics for cardiovascular drugs. And the three drugs I'm going to cover today are metoprolol, clopidogrel, and statins. And then I'll finish with some of the major recent changes that have really been advancing the clinical use of pharmacogenetics for cardiovascular drugs within the past few years. So let's get started with some brief background on what is pharmacogenetics. So the terms pharmacogenetics and pharmacogenomics and PGX, they're all kind of used interchangeably. They all kind of mean the same thing. It's the field of research and clinical practice that assesses how patients' genetics influence their responses to drugs. So we know as clinical pharmacists, there are many things that influence how our patients respond to their medications. There's several different biological factors, such as their age, sex, kidney function, liver function, drug-drug interactions, and then there's also environmental and social factors that we take into account when how our patients are treated. Like in the U.S., I have to know whether the patient can afford the medication that I would like to use in them, or does their insurance cover it? Do they have a pharmacy in their neighborhood? If not, does there a pharmacy that can deliver to their house? So there's lots of hype recently about, precision medicine and how it's like being sold as like a new concept. But I think as pharmacists, we already practice precision medicine. We already take into account many different biological factors and environmental or social factors to optimize our patients' medication therapy. It's just that their genetics or their DNA is a new biological factor that we also should be taking into account now. So when I explain this to physicians, I tell them this to think, this isn't a completely new concept. It's just a new biological factor. And also when I explain it to them, when I show them the effects of these genetic variants are actually very similar to drug-drug interactions that we already know how to manage, then I feel like that makes this seem like it's not a totally new concept. We're already practicing precision medicine. So that's my brief background on what is pharmacogenetics. I think it'll make more sense as I go into these specific examples of for these three cardiovascular drugs and drug classes. So now I'm going to cover, what are the current clinical practice guidelines and recommendations for pharmacogenetics of cardiovascular drugs. And before I go into the three specific examples, I'm just going to give you an overview of, where do we get recommendations. So in the US, we have three main organizations that are providing cardiovascular pharmacogenetic recommendations. So that's CPIC, or the Clinical Pharmacogenetics Implementation Consortium. CPIC is the newest of these three organizations. So actually, probably most clinicians in the US still haven't heard of CPIC. It's about 15 years old. It is, funded by the US National Institutes of Health. It's a registered service mark of the U.S. Department of Health and Human Services. And the purpose of CPIC is specifically to publish pharmacogenetic clinical practice guidelines. Also, the FDA has two different pharmacogenetic resources online, two different websites. The first is a table of pharmacogenomic biomarkers and drug labeling. So any drug that has pharmacogenetic information in its FDA-approved label is listed in this table. But it's also really challenging for the FDA to change drug labels. And, we've used some of these cardiovascular medications for many years. So they're old drugs, and it's hard to update labels for old drugs, especially if they're generic. So the FDA has this second pharmacogenetic resource online that's the Table of Pharmacogenetic Associations. So these are genetic variants that FDA thinks have a therapeutic effect, but it just hasn't been implemented into a drug label officially. And then finally, there's the American Heart Association. So the American Heart Association has published several statements that include information on pharmacogenetics. So this includes scientific statements and policy statements. the the challenge with the statements is they're technically not allowed to make clinical recommendations. Only guidelines published by AHA make clinical recommendations. Um, and unfortunately, there's very limited pharmacogenetic clinical recommendations in AHA guidelines so far. So, because we have three different organizations providing pharmacogenetic clinical recommendations in the US, and all three of these organizations have different purposes and processes, sometimes the recommendations conflict, and so that has been a challenge. It's like, well, which recommendation do you follow if they differ? So, a long story short, of these three organizations, the US health systems that are implementing pharmacogenetic testing, they're primarily following CPIC guidelines. And I said in the beginning, I'm a CPIC member and author, so obviously I'm biased, but there's many reasons why CPIC guidelines are the best resource for pharmacogenetic recommendations. I could talk more about that if you'd in the question and answer session if you'd like to know. But CPIC has a transparent and systematic evidence review process and provides specific variant information and clinical decision support, and lots of resources that help the clinical use of pharmacogenetics the best. So when I'm going to be presenting clinical practice guidelines in the rest of this presentation, this is why I'm going to be showing you the CPIC guidelines. So now that I've given you an overview of where our clinical recommendations come from for cardiovascular drugs in the US, I'll start with our first example, which is metoprolol. So here's some quick background on how genetic variants can affect patients' response to metoprolol. So we all know that the primary pharmacologic effect of metoprolol is to inhibit beta-1 adrenergic receptors in the heart to significantly slow heart rate. But how does metoprolol exit the body? How is it metabolized from the body? So metoprolol is primarily metabolized by the enzyme in our liver called CYP2D6. And unfortunately, some of us and some of our patients, our DNA code for this enzyme encodes a basically broken CYP2D6 enzyme. It does not work. It does not metabolize drug. It's completely non-functional. And so when I looked up like how frequent these genetic variants are, I looked this up for sub-Saharan Africans. The allele frequencies of these variants differ depending on what your patient's ancestry is. So I realized sub-Saharan Africa is a very large region, including lots of different countries and ethnicities of people, but this is the most granular of frequency data I had available. So the frequency data says that approximately 2% of sub-Saharan Africans have a genetic variant that encodes non-functional CYP2D6. So maybe about 1 in 50 of your patients, their CYP2D6 enzyme does not work, and so they're not able to metabolize metoprolol. So in patients with these genetic variants, even on like very low doses of metoprolol, they're at risk for bradycardia because their body is not able to metabolize the metoprolol. So this has been shown in several studies, and I have the PMIDs here for some of those studies for your reference. So like I said, the population frequencies of genetically determined CYP2D6 metabolism varies depending on the patient population. Here in Southeast Michigan, our patient population is predominantly European ancestry, which has the highest frequency of these non-functional CYP2D6 enzymes. And probably, I'm assuming for this audience, you're most interested in the African populations where the frequency is about 2%. So here's a very simplified summary of the clinical practice recommendations for pharmacogenetics for metoprolol. So if you know your patient's genetic test results, their genetically determined CYP2D6 metabolism, they could fall in one of four categories. They could have ultra rapid, normal, intermediate, or poor CYP2D6 metabolism based on their DNA code. So for most of our patients, they have their CYP2D6 enzyme works and works enough to metabolize metoprolol. So this would just be standard metoprolol selection or dosing for most of our patients. It's this small subgroup of patients that are poor CYP2D6 metabolizers where we want to be more careful in starting and titrating metoprolol. So the guideline recommends to initiate metoprolol at the lowest possible starting dose and more carefully monitor for bradycardia at dose increases. So when we wrote this CPIC guideline, we looked at, does CYP2D6 genetic variants affect beta blockers other than metoprolol? And the evidence for other beta blockers was not very strong. So really, we thought the evidence was only strong enough for the effects of these genetic variants only on metoprolol and not other beta blockers. There's also been studies of lots of other genes, like these are pharmacodynamic genes related to beta blockers. And again, the evidence wasn't very strong for those either, so no recommendations for those. So I have some review questions in here. I know it's like getting late in the evening there, so maybe this will help you stay awake during a webinar. So here's our first review question. Patients that have genetically determined poor CYP2D6 function have increased risk of bradycardia with which of the following beta blockers? Is it A, atenolol, B, bisoprolol, C, carvedilol, D, metoprolol, or E, all of the above? You can respond in the chat if you'd like, or just think about the answer to yourself. And the correct answer is D, metoprolol. It didn't seem like the evidence for effects of genetic variants on any other beta blocker at this point was strong enough to make any clinical recommendations. All right, so that's my quick summary of the clinical recommendations for pharmacogenetics of metoprolol. So now let's talk about clopidogrel. So some brief background on how genetic variants affect patients' response to clopidogrel. So you all probably know clopidogrel is a prodrug. So that means the drug in the tablet that the patient swallows is inactive. It doesn't inhibit platelets. The clopidogrel has to be activated in vivo in order to inhibit platelets. So the question is, how is clopidogrel activated in the body? So it's primarily activated by an enzyme in our liver called CYP2C19. And just like CYP2D6, some of us and some of our patients, our DNA code for this enzyme encodes a broken enzyme. It either doesn't work as well as other people, or in some patients, this enzyme doesn't work at all. And so when I looked up the allele frequency for these genetic variants, this was very common in sub-Saharan Africans, where as many as about 40% of sub-Saharan Africans have genetic variants that cause decreased or loss of CYP2C19 enzyme function. So patients with these genetic variants, they're not activating clopidogrel enough or barely at all. So patients with these genetic variants, and it's been shown in several studies now, even if they're taking their clopidogrel, they're still at significantly higher risk for heart attacks, strokes, and even death when taking clopidogrel because they're just not activating enough to inhibit the platelets. So here's the population frequencies of genetically determined CYP2C19 metabolism. And like I said, for sub-Saharan Africans, it's estimated that almost 40% have genetically determined poor or intermediate CYP2C19 metabolic function. So here's a simplified summary of the clinical practice guideline recommendations for clopidogrel pharmacogenetics. So depending on the patient's genetically determined CYP2C19 metabolism, if it's ultra rapid or normal, then there's just standard clopidogrel selection or dosing, because these are patients where they're able to activate enough clopidogrel for it to be effective. But it's patients who are intermediate or poor CYP2C19 metabolizers, they're not activating enough clopidogrel. So the CPIC guideline recommends to avoid clopidogrel if possible and use an alternative antiplatelet medication depending on the indication. So, two main indications here in the US are, for after a stroke or after acute coronary syndromes. And we have two other P2Y12 inhibitors that are available, and that's prasugrel and ticagrelor. And I think just when I tried to look it up, which are available in Nigeria, I can't remember which one, but I think it's only one of these. So when we looked at this gene, CYP2C19, and these other two P2Y12 inhibitors, there was really no strong evidence of effect. So that's why other P2Y12 inhibitors are reasonable substitutes for patients who don't who have these genetic variants. We also looked at a lot of other genes, different pharmacokinetic, pharmacodynamic genes that have been studied, but again, the evidence wasn't very strong for those to warrant a clinical recommendation. So really, this just focuses on genetic variants in CYP2C19, and they only affect clopidogrel. So here's our next review question. Clopidogrel should be substituted with an alternative antiplatelet medication in which of the following patients? Is it A, CYP2C19 ultra-rapid metabolizers, B, CYP2C19 intermediate metabolizers, C, CYP2C19 poor metabolizers, or is it A and B or B and C? So again, you can respond in the chat or just think about the answer yourself. And the correct answer is B and C. So patients who are CYP2C19 intermediate or poor metabolizers, because of their genetics, they're not activating enough clopidogrel for it to be effective and prevent future heart attacks or strokes. So the next drug class example I want to talk about are statins. So here's some background on how genetic variants can affect patients' response to statins. So we know the primary the primary mechanism of action of statins is to inhibit the HMG-CoA enzyme in the liver, which reduces LDL cholesterol synthesis. The liver is also the site of the body that metabolizes and excretes most statins. So the question is, how do statins get into the liver? Well, a lot of statins are transported into the liver by this enzyme encoded by the gene SLCL1B1. But again, some of our patients, our genetic code for SLCL1B1 encodes an enzyme that doesn't work or has decreased function. So I looked it up, and it's estimated that 5% of sub-Saharan Africans, or maybe 1 in 20 of your patients, have a genetic variant that causes decreased or poor SLCL1B1 function. So if the statin is in these 5% of patients, if they're not transporting the statin into the liver, then what does that mean? That means there's higher blood concentrations of the statin in the blood and the circulation. That means higher exposure to muscles. And in the US, muscle side effects are the number one reason why our patients won't take statins. So I assume it's probably the most common side effect in your patients too. So this has been shown in many studies, and here's 3 examples uh, of that patients with these genetic variants have significantly higher blood levels of statins and also significantly higher risk of muscle problems on statins. What makes this a little more complicated than the 2 previous examples I went over is that different statins are affected by these genetic variants differently. So genetic variants have the biggest effect on simvastatin, pitavastatin, and atorvastatin, and pretty negligible effects of variants in this gene on pravastatin, rosuvastatin, or fluvastatin. So you might be like, well, why don't we just use rosuvastatin in everyone and not worry about this? Well, these other statins are transported by different transporters that have genetic variation in them too. So, for example, rosuvastatin, it's transported into the liver not by SLCO1B1, but by the transporter encoded by the gene ABCG2. And still, 1% of sub-Saharan African have genetic variants that decrease ABCG2 function. And then it's been shown in multiple studies that patients with these genetic variants have significantly higher blood levels of rosuvastatin, and presumably that increases their risk for muscle problems.
你这个想至
And,
於資料嘅話，佢哋都
and then also for fluvastatin, it's metabolized by CYP2C9, and 27% of sub-Saharan Africans have genetic variants that decrease CYP2C9 function. So these genetic variants may increase risk with fluvastatin. So here's a screenshot of the clinical practice guideline recommendation for pharmacogenetics of statins. It's much more complicated than the two previous one gene, one drug example because different statins are affected by different variants. But how we structured this figure and this guideline was based on the American Heart Association uh, guidelines for cholesterol management, where they recommend different intensities of statin based on the patient's risk for how much at risk they are for atherosclerotic cardiovascular disease. So we subcategorize these high, moderate, and low intensity statin recommendations in the AHA guidelines by, based on the patient's genetic profile, which statins have the lowest risk of muscle symptoms. So in this screenshot, if your patient has genetically determined SLCO1B1 poor function, and let's say they need a high intensity statin, usually the AHA guideline says either rosuvastatin or atorvastatin could be used. But because atorvastatin is affected by these genetic variants, rosuvastatin would have lower risk of statin-associated muscle symptoms. And here's the screenshot for if your patient has SLCO1B1 genetically determined decreased function. The recommendations are pretty similar to the last slide where for patients with SLCO1B1 poor function. And then also, like I said, rosuvastatin is transported by a different enzyme encoded by this gene ABCG2. So for patients with genetically determined ABCG2 poor function, you'd want to dose rosuvastatin more carefully or use a different statin. And for patients with genetically determined CYP2C9 intermediate or poor function, it's recommended to dose fluvastatin more carefully or use a different statin. And then when we looked at studies of these other pharmacodynamic and pharmacokinetic genes, the evidence wasn't strong enough to warrant clinical recommendations. All right, so here's our next review question. Genetic variants in which of the following genes significantly increase patients' blood levels of statins, thereby increasing their risk for muscle symptoms? A, SLCO1B1, B, ABCG2, C, CYP2C9. Is it all of the above or none of the above? And the correct answer is all of the above. So the statins, it's a little more complicated because we have genetic variants in multiple different genes affecting multiple different statins in different ways. So that's my really brief summary of like what are the main clinical recommendations for pharmacogenetics for cardiovascular drugs. So I wanted to talk a little bit more about now about how these recommendations are actually being used in U.S. health systems because there in the past few years there have been some major recent changes that are really pushing the clinical use of pharmacogenetics in the U.S. So this is how it usually goes. I'll like teach cardiologists about pharmacogenetics, and they'll look at me skeptically and have lots of objections to it. And what most of them said, the first thing they'll say to me is, "Well, there aren't any prospective randomized controlled trials showing that using pharmacogenetics significantly improves clinical outcomes for patients with cardiovascular disease." So Dr. Usman mentioned in the beginning, yes, pharmacogenetics is, being more commonly used in psychiatry, infectious disease, and definitely in cancer. And I think cardiologists recognize this, but they don't realize now that there are multiple randomized controlled trials showing that, when patients were randomized to either genetic guided cardiovascular drug therapy or our standard of care, which is not genetic guided cardiovascular prescribing, the genetic guided cardiovascular drug prescribing also significantly improves patient outcomes. So here's screenshots of some of these major randomized controlled trials showing that genetic guided prescribing of different cardiovascular drugs significantly improves patient outcomes. I don't have time to go over all of these trials. I do want to review one of these landmark trials though today, and that's the PREPARE trial. This is like the most recent landmark one. It was published in Lancet in 2023. And here's the title. It was a 12-gene pharmacogenetic panel to prevent adverse drug reactions. It was an open-label, multi-center, controlled, cluster randomized crossover implementation study. So the PREPARE trial was done in 7 different countries in Europe. So they're in red on this map. And it was pretty interesting when patients were randomized to the genetic guided drug prescribing arm. They were given a card like this. It was like the size of a business card that they could keep in their wallet. And it had this QR code on it that the healthcare provider could scan. And it says to the healthcare provider, please scan the QR code to view pharmacogenomics-based drug dosing recommendations for this patient. So they could scan this QR code and then it would appear on their mobile device, pharmacogenetic recommendations for the patient. Or there's a summary on the back of the card. So for example, this patient, Jane Doe, for her CYP2C19 gene, she's actually a poor metabolizer, and the critical drug substances where a modification is recommended included clopidogrel and sertraline. And you can see she's also a CYP2D6 ultra rapid metabolizer, TPMT poor metabolizer, other genes tested, but she's a normal metabolizer for all these other genes. So you can see that, we know drug metabolizing enzymes aren't cardiovascular specific or infectious disease specific. They metabolize a variety of drugs. Um, but in this trial, the most commonly prescribed drugs were for cardiovascular disease because of the high prevalence of cardiovascular disease. So the number one most the target drug in this trial that was genetic guided therapy was atorvastatin. Number 2 was clopidogrel. Number 4 was simvastatin, and then also warfarin, metoprolol, and acinocumarol were also in the top 20. So even though this trial wasn't specifically designed for cardiovascular drugs, they were the most commonly used. And so obviously genetic guided prescribing can improve not just psychiatric drugs, cancer drugs, or infectious disease drugs, but also cardiovascular. So here's a quick overview of the PREPARE trial design and results. So it included nearly 7,000 patients. They were randomized to either genotype-guided drug therapy or standard care. There was 12 weeks of follow-up. The primary outcome was causal and clinically relevant adverse drug reactions. So they used established and validated tools to first determine the causality of the adverse drug reaction. Was this reaction really caused by a drug or something else that was happening with the patient? And if it was causal, then they graded how clinically relevant was it. So they only counted clinically relevant adverse drug reactions. And what they counted as clinically relevant was any adverse drug reaction that prompted an interaction with a healthcare provider. So here's the rates of the primary outcome in the genetic guided and standard care group. So in the genotype guided drug treatment group, the rate of adverse drug reactions was 21.5%. And then in the standard care group, it was 28.6%. So this results in an odds ratio of 0.70, which was statistically significant for the genotype guided group. This means there was a 30% relative risk reduction for adverse drug reactions, a 7% absolute risk reduction in adverse drug reactions, which translates to a number needed to test of 14. So if we do this 12-gene pharmacogenetic panel in 14 patients, then we'll prevent one clinically relevant adverse drug reaction. So this is like all the cost effectiveness studies that have come out after this trial have shown that pharmacogenetic testing is highly cost effective because, as I'll cover later, the cost of genetic testing has really come down in the past several years. So this is big news. I mean, the FDA says that adverse drug reactions are the 4th leading cause of death in the United States. Like this is crazy. We're supposed to be using medications to save lives, not to cause death. So more Americans die from adverse drug reactions than pulmonary disease, diabetes, AIDS, pneumonia, accidents, and automobile deaths. So this PREPARE trial is really big news, could have a really big public health impact because now we have prospective randomized controlled trial evidence showing that using pharmacogenetics significantly reduces patients' risk of adverse drug reactions. So even showing cardiologists this randomized controlled trial evidence, the next thing they tell me is like, well, the pharmacogenetic tests, they're just too expensive. So there has been, this is not really the case much anymore. The cost of pharmacogenetic testing and any genetic testing has declined rapidly. So I know these costs may not mean much to you in US dollars, but I will put them in context of other labs that are routinely ordered in cardiology. So for example, say you wanted to test just a single pharmacogenetic gene, like you have a patient coming into the cath lab, they need antiplatelet drug therapy, and you want to know if it's safe to use clopidogrel. So you just want to test CYP2C19. So a single pharmacogenetic gene test cost could be around $150 in the US. It's actually more cost efficient. You could test multiple pharmacogenetic genes in a single test. So like the PREPARE trial, they tested 12 genes in a single test, and those are about $250 to $400. And to put this in perspective, here's the cost of other labs that are routinely and serially ordered like in routine cardiovascular practice. So like a single NT-proBNP even costs more than a single pharmacogenetic gene test cost. And even a lipid panel is similar cost. So these labs like BNP and lipids, they can change over time. So we need to order them over time. But since our DNA doesn't change, unlike these other lab tests, we only need to order a genetic test once in a patient's lifetime. So unlike most clinical lab tests, genetic tests only need to be ordered once in a patient's lifetime. And because our DNA doesn't change, we could order the genetic test before the patient starts taking the relevant drug. So for example, we only order a lipid panel, several weeks after the patient's already started a statin. But a pharmacogenetic test, we can do the test before the patient starts the statin, and based on their genetic profile, try to choose the statin that has the lowest risk of muscle symptoms for that patient. So the cost of genetic testing is pretty similar to other regular kinds of clinical tests in the US at this point. So even with these low costs, the next thing cardiologists tell me is like, well, they're not covered by health insurance in the US. This is also not the case anymore. So here's reimbursement data from the University of Florida, which is one of the first health systems in the US to start implementing pharmacogenetic testing in clinical practice. And so on the y-axis, we're looking at reimbursement rates and across different therapeutic areas, psychiatry, cardiology, gastroenterology, and pain. So they had 4 patients that got a multi-gene panel test for cardiology, and they were 100% reimbursed. And a single gene test for CYP2C19 was reimbursed in half of the patients. When the insurance doesn't cover this, the patient has to pay for it themselves. Um, but these pharmacogenetic test reimbursement rates are expected to increase because of the recent Medicare local coverage determination. So Medicare is the largest health insurer in the US. So usually whatever Medicare does, then all of the other health insurance companies will follow. So here's a screenshot from the U.S. Centers for Medicare and Medicaid Services, or CMS. This talks about their local coverage determination for pharmacogenomic testing. And to summarize it, pharmacogenetic tests are now covered in all 50 states by Medicare if they have pharmacogenetic recommendations from CPIC or FDA. So even if cost is not an issue, insurance coverage is not an issue, the next thing cardiologists will tell me is like, well, I just can't order the tests. My health system doesn't offer pharmacogenetic testing, so I'm not able to order it. So this is not true anymore either. There's lots of different ways to order pharmacogenetic testing and that it's available to patients and providers. So, for example, many more health systems in the US are now implementing pharmacogenetic testing. So we published a study back in 2017 of, at that time there was only like seven initial large academic health systems in the US that were implementing pharmacogenetic testing. And then fast forward 20 to 7 years later to 2024, now there's over 50 US health systems that are implementing pharmacogenetic testing. If you want to see what they all are on the CPIC website, there's an implementation website, and any health system that has started pharmacogenetic testing and like who is their contact for that program is listed on the CPIC website. So lots of providers may not be aware that their own health system might be offering testing now. And this includes our health system. So our health system is called Michigan Medicine. And what may be interesting to you all and this audience, we have a clinical pharmacist pharmacogenetic service at Michigan Medicine. So we have two pharmacists who are pharmacogenomic experts. So Amy Pasternak, she's our pharmacogenetic clinical pharmacist in the hospital, and Kristen Ward is an ambulatory psychiatry and pharmacogenomics. And I'd be sure if any of you wanted to contact them, I'm sure they'd be happy to discuss their experience with any of you. So like Dr. Usman said, pharmacogenetic testing is, getting adopted more in other therapeutic areas than cardiology, and psychiatry is one of those areas. So what I try to remind our cardiologists is that patients can get pharmacogenetic test results from their other healthcare providers, for example, in psychiatry, that also may apply to their cardiovascular drugs. So one kind of pharmacogenetic test that is commonly ordered to help identify or optimize psychiatric medications in the US is called GeneSight. So this is a screenshot of an example of what this GeneSight pharmacogenetic test report looks like. So even though their provider probably ordered this test to help choose the most effective psychiatric medication, because there is a lot of trial and error in for psychiatric medications, these are the same genes that metabolize cardiovascular drugs. So we covered that CYP2D6 metabolizes metoprolol, and CYP2C19 metabolizes clopidogrel. So our cardiologists may not be aware that these pharmacogenetic test results are in their patients' charts and can affect their cardiovascular medications. Also, the US now has this genetic testing registry where healthcare providers can look up any genetic test for anything they want to test for. So this is a screenshot I took of this just yesterday, and I searched for genetic tests for statin-induced myopathy. And the results include 8 genetic tests from 7 different labs that provide pharmacogenetic tests for statin-induced myopathy. So you can just click here, and it takes you to information of the lab and where to order it and what genes are included and what are the methods for the test. And then I have a true or false question for you guys. So, most labs and clinical tests need to be ordered by a healthcare provider. But what about for pharmacogenetics? Is it true or false that patients in the US can order pharmacogenetic tests for themselves? What do you think? This is true or false? This is
I
actually
think it's
true.
really true. True.
Yeah, yeah, it's actually
Yeah,
true.
it's true.
Um, it's kind of scary, kind of interesting that the FDA made this decision. So the FDA approved direct to consumer pharmacogenetic testing from the company 23andMe. So it includes 33 variants and 8 genes, including variants in the genes that affect the cardiovascular drugs that I covered today. So CYP2D6, CYP2C19, SLCL1B1, and CYP2C9. So last I checked, it was $199. This is not covered by health insurance. So um, patients can order this themselves, but they have to pay out of pocket for it. And this is like an example of what the pharmacogenetic summary report header looks like. So yeah, so the patient just sends a saliva sample, they self-collect it, and they submit it by mail, and they get pharmacogenetic test results. So most of these results do have to be confirmed by a test ordered by a healthcare provider, but the FDA made two exceptions. They said all of the pharmacogenetic test results from 23andMe require confirmatory clinical testing, except for citalopram and clopidogrel. So basically, what the FDA is saying is like this test that any consumer can order for themselves, the results are just as good as any clinically ordered test by a healthcare provider if it's for clopidogrel or citalopram. So this was a very interesting decision by the FDA. So even if, we can afford the test, we can order the test. The next thing cardiologists tell me is like, well, there's just no place for pharmacogenetics in the electronic health records. This is also not true anymore. So our electronic health. Oh,
Well,
okay. So just make sure I keep hearing sound, so please make sure you're muted. Um, So our electronic health record is by Epic, and our version of Epic is called MyChart. Everything in Michigan starts with M or My. And to find genetic test results, you can search genomic, and then it jumps to genomic indicators. So these are screenshots from our EHR. And this is what the genomic indicators section looks like. So on top, they have genetic test results for any diseases. So like this patient has familial hypercholesterolemia, and they had genetic testing for that. And then there's below that are the pharmacogenetic test results. So this patient also had testing for CYP2C19, but they are a normal metabolizer for CYP2C19. So actually this patient, clopidogrel, could be used just fine. But we do have here's an example of one of our existing cardiovascular alerts. So we have an existing clopidogrel pharmacogenetic alert in MyChart, and it's for patients with a CYP2C19 intermediate or poor metabolizer result that's already available at the time of post PCI order set entry. So when they go to place the order set after PCI, like I said, we have three P2Y12 inhibitors available: clopidogrel, prasugrel, and ticagrelor. So it has the warnings for prasugrel on top and the warning for ticagrelor. But this patient also has pharmacogenetic test results. So in this yellow part, it says, based on pharmacogenetic testing, this patient is expected to have reduced response to clopidogrel. Consider use of an alternative antiplatelet agent. Please consult your treatment team pharmacist or the pharmacogenetics service, which is the in-basket to our pharmacogenetic clinical pharmacist. So you can notice like it recommends to choose an alternative drug, but it doesn't require them to. So they could still pick clopidogrel even if it's a high risk patient, but then they usually have to document why they overrode this pharmacogenomic warning. So even though we've overcome all of these practical logistical barriers to using pharmacogenetics in clinical practice, cardiologists will still tell me, well, it's still not recognized as a standard of care. This mostly comes from the fact that there's really limited recommendations in our American Heart Association guidelines. It's in AHA statements, but not guidelines. So even though the American Heart Association and cardiologists are slow to adopt pharmacogenetics, it's almost like there's increased public awareness faster than in cardiologists. So this is a screenshot of a news article. It says OHSU to pay $1 million, promises change to settle lawsuit from widow of cancer patient. So this was a pharmacogenetic-based lawsuit. So the man in this photograph is David McIntyre, and he had cancer and was being treated at Oregon Health and Science University. And there's a rare but potentially fatal adverse reaction to the chemotherapy used to treat his cancer. But there is a pharmacogenetic test that can identify patients who are high risk for that adverse drug reaction. He did not get that pharmacogenetic test, and he did have that rare fatal adverse reaction to his chemotherapy, and he died. But the wife knew about this, the availability of this pharmacogenetic test. So it was really sad because he did not die from his cancer. He died from his cancer treatment. And so his wife sued the healthcare system because they hadn't done the pharmacogenetic test, which could have prevented his death. And she won, and it was $1 million. So this is a cancer news headline, but there's also news headlines for cardiovascular pharmacogenetics too. So this is a screenshot. This news article says Bristol Myers Sanofi, which is the maker of brand name Plavix or clopidogrel, was ordered to pay the state of Hawaii $834 million over the Plavix warning label. Um, so uh, the genetic variants that cause loss of CYP2C19 enzyme function are very frequent in patients with Oceanian ancestry and East Asian ancestry. And since the majority of the citizens of the state of Hawaii have Oceanian or East Asian ancestry, the state attorney general of Hawaii sued the company that makes brand name Plavix, saying, you knew you were selling an ineffective drug to the majority of the citizens of the state of Hawaii. And the state of Hawaii won this lawsuit because lots of Hawaiians were dying, even though they were taking their clopidogrel, they were having heart attacks and strokes. And so they had these genetic variants that were making the clopidogrel ineffective. And so this money is being paid to those patients that had heart attacks and strokes and their family members if they died when they were taking clopidogrel. So there is more public awareness of pharmacogenetics that is kind of driving and motivating cardiologists to be more aware of this. So another thing that cardiologists tell me was, well, there's just no clinical practice guidelines for pharmacogenetics of cardiovascular drugs. So now, and you all know, based on this webinar, there are lots of recommendations and guidelines available now. So here's my last review question. Which of the following major recent changes have facilitated the clinical use of pharmacogenetics in the USA? A, do we now have prospective randomized controlled trial evidence showing pharmacogenetics significantly improves patient outcomes? B, is there lower cost for pharmacogenetic testing? C, is there improved insurance coverage of pharmacogenetic testing? D, improved availability of pharmacogenetic testing? Or E, all of the above?
All of the above?
You are correct. We have all of these things now.
Sure,
So
sure.
yeah, just I have been really impressed how far and fast the field has come in the past few years. So that is everything I wanted to cover today. So I'll just summarize the main points. First, that pharmacogenetics is the field of research and clinical practice that assesses how patients' genetics influence their responses to drugs. Patients have genetic variants that decrease their ability to metabolize some of the most commonly prescribed cardiovascular medications. And the three examples I covered today are metoprolol, clopidogrel, and statins. And many major recent changes have greatly facilitated the clinical use of pharmacogenetics in the USA. So here's a quick summary of the therapeutic recommendations. So metoprolol should be dosed more carefully in patients that have genetically determined poor CYP2D6 metabolism. Clopidogrel should be avoided in patients that have genetically determined intermediate or poor CYP2C19 metabolism. And statins with the lowest risk of SAMs or statin-associated muscle symptoms should be selected in patients with genetically determined decreased or poor SLCO1B1, ABCG2, or CYP2C9 function. So here's a plug for if you are looking for further training in this. The American Heart Association has an online genetic certification course available. This is really broad. It covers genetic testing for disease as well as pharmacogenetic testing, but I taught the pharmacogenomics module in this, so that's why I'm advertising it here. What may be more relevant for this audience is the American College of Clinical Pharmacy has a pharmacogenetics certification designed for clinical pharmacists. So they have this ACCP Precision Medicine Applied Pharmacogenomics Certificate Program. It's an interactive practice-based program designed to help clinical pharmacists understand how genetic factors influence the efficacy and adverse effects of drug therapy. And I work with a lot of amazing groups to help me with this work. And thank you all for your attention. And I'd be happy to take down my slides and answer questions.
Oh, this is nice. I predicted it, and it never disappoints. Thank you very much, Dr. Jasmine. I think this is a kind of lecture that is so incisive, so provocative, very short and precise and direct to the point. I think
Good.
the points are very clear, and everything about the lecture is well crafted, and I'm sure everyone in this webinar must have had a lot to reflect over. It's very, very, in fact, so possibly before I invite questions, comments, and observations, it is very important to, if you remember my introduction when I was trying to introduce the precision medicine, I almost try to summarize what we are going to be hearing from Dr. Jasmine. And one part that excites me more is when I look at the case scenario she gave us about the cancer patient who died not as a result of the cancer, but as a result of the adverse drug problems that is as a result of lack of genetic testing. This is actually mind blowing, and from there you know, especially in the sub-Saharan Africa where this type of sophistication do not exist, where this type of sophistication to identify specific genes, and the cost of this here in Africa there is no insurance, and I think the availability is very effective. So definitely it's going to be very, very challenging here. But at least the knowledge is well taken. And I think it's going to change our trajectory as clinicians, and we're going to continue to work together. You can see this lecture actually try to summarize. In fact, she used 3 drugs, and those drugs, metoprolol, clopidogrel, and statins. And of course, just like she said, this is not new, especially in the world of pharmacy where we know about cytochrome P450 enzymes and their classifications. We know how very, very specific they are in metabolizing specific drugs and other chemicals in the body, in the biological system generally. And once a particular drug, which usually according to the all one size fits all, I said, where you have guidelines developed based on age, sex, weight, severity of the disease, renal function, and liver function. These are the kind of guidelines we use in managing our patients. But when you look at the guidelines that she has gone through with all of us, is a guideline that, while it takes into consideration all other things the standard guideline takes care of, here the guideline is very, very specific to individual patients. A patient with type 2D6, another patient with deficiency, another patient with excessive levels will definitely have different concentrations of metoprolol. And the moment you have high level of metoprolol in the blood that has not been metabolized, you expect the heart to go into bradycardia. And bradycardia, you know the problem. And when you go to clopidogrel, if clopidogrel is being deactivated very fast, then you expect the risk of heart attack, death to increase. And of course, when you go to statins, if statins are not also being moved into the liver and they are left in blood concentration, in high concentration in the blood, you expect muscle problems. In fact, I think the term we use, I think I can easily remember rhabdomyolysis. I think that's one of the muscle problems which she was explaining. She tried to be very, very simple without bringing the term. Thank you very much for this. And you can see the difference between the two guidelines. And actually, I must say we thank you very much for this. Just like I predicted, at the end of this lecture, we're going to have a change of mind. And of course, a lot of us are going to begin. In fact, I am very sure a lot of us are going to start to develop interest in cardiology pharmacy, because what she has told us now is not just about cardiovascular. It's about every other disease condition. You can see the example she gave was about cancer. When you go to infectious disease, it's the same thing. When you go to other disease conditions, it's the same thing. There are specific genes associated with specific disease conditions. So all these are the same. So thank you very much. And I think at this juncture, I will invite questions. If you have any question, you can raise your hand. I think I can see Nafi Yusuf raising your hand. You can unmute yourself and ask your question. Nafi?
Good evening, everyone. I would like to start by thanking the presenter, Dr. Jasmine, for the wonderful presentation, and Dr. Nuru for moderating this session. Thank you very much, Ma. Thank you very much, sir. My question is this. I want to ask who carries out the pharmacogenomics testing? I mean, does a pharmacist, can a pharmacist allowed in the USA to carry out pharmacogenomic testing? Thank you very much. That's the question.
That's a good question. And the answer is it depends. When we studied like the first health
Talking about specific testing, not order for the test. The specialties. Yeah.
It's usually not the pharmacist. I mean, depending on what state you're in, like how much pharmacists are allowed to order, really depends on the laws of that state. So it varies by state. If some pharmacists have a collaborative practice agreement with a physician, some pharmacists can order pharmacogenetic testing, but usually it's the physician that can order the testing. And I wanted to make a point.
Yes.
I should have said this earlier, that I would really encourage you all to do research in pharmacogenetics. I mean, one of the major limitations of the field is most of the data we have is from patients with European ancestry. And when it comes to genetic research, that really limits what we can discover if you're only studying patients with like a certain homogeneous ancestry. And since, humans evolved from Africa, there's way more genetic variation in Africans. So there's way more that we could learn from pharmacogenetic studies of Africans. So I would really encourage you all to get involved in the field and expand what we can learn in pharmacogenetics.
So any other question, please? Let me check the chat box. Yes. Abiodun?
Yeah, thank you so much. Good evening, everybody. And thank you so much for the wonderful presentation. It was actually a very, very big one for me because I take care of elderly people. So they come down with all sorts of adverse drug reactions and all that. One question I want to ask is that you talked about ineffectiveness when the person is a poor metabolizer of a particular medication. Are we talking about toxicity as well? Because I had a situation during the week whereby a patient came in and she was actually having chest pain because of clopidogrel. So it just occurred to me while the presentation was going on that could it be the fact that she wasn't able to metabolize the drug very well, or could it be as a result of an adverse drug reaction? Because one of the side effects of clopidogrel is chest pain. So I just want to ask, because you talked about ineffectiveness, what about toxicity now? Where does it stand when it comes to pharmacogenomics? Thank you. Over.
Yeah, I mean, I think it depends on the drug. Like, so since it could affect either efficacy or toxicity. So for like the statin example, those genetic variants, they're increasing blood levels, which is increasing exposure to muscle, and so increasing a toxic effect. Um, so you'd think if the statin is also not getting into the liver, then it should also not have as much efficacy either. But although like the efficacy data for the statins isn't as strong, so we can only make recommendations for what has the strongest evidence. And so like statins are an example where the evidence was way stronger for genetic variant effects on toxicity than effectiveness. For clopidogrel, it seems like it's more for the evidence was stronger for lack of effectiveness if the patients aren't activating the clopidogrel. But also it has been looked at the other side, for patients who are ultra rapid CYP2C19 metabolizers, you'd think if they're taking clopidogrel, they're activating a lot of clopidogrel, so they should be at risk for higher bleeding events. But the evidence hasn't really been strong for that. So it could go either way, I think. Either way, effects on efficacy or toxicity. But this is like what I presented today is what the strongest evidence supports so far.
All right, thank you.
Thank you very much. Any other question? Yes.
You could probably also see my email address on my faculty website or LinkedIn. So if you think of questions later, feel
Yes,
free to
yes.
send me an email.
And maybe I will ask on behalf of the community so that you help us with the documents, the slides, possibly
Yes.
after the presentation.
Yes, I can share
And
my
also,
slides.
you talk about the two clinical pharmacists in one of the hospitals. Possibly, I could see their address on the slides, so we will try to either contact them directly or through you. At least we've been able to establish contact with you, so we'll continue to maintain that contact.
Yeah, in the Pharmacogenomics Research Network, so their website is like pgrn.org. There is a clinical like pharmacogenomics group. So if you're interested in this, like there's groups of clinical pharmacists who are also interested in pharmacogenetics that you could link up with.
Thank you very much. Yes. So any other question?
Okay, good day all.
Okay.
Yeah. Okay, so I just want to understand, Professor Jaspin, I want to understand why more attention was paid to metoprolol and clopidogrel, because I know that we have other antihypertensives. So yeah, so like the popular
Yeah, it's
ones like the
coming.
CCB. Yeah,
Yeah,
so
I
like the
mean,
amlodipine. So
yeah,
I just want to know.
I
Hold on.
agree. Like, we don't really use metoprolol for hypertension much anymore. Where it's more commonly used is for heart failure, and some arrhythmias, but we still use metoprolol is actually still the I think no, it's definitely in the top 10 of all prescribed drugs in the US. So it's still used a lot for other cardiovascular indications, but yeah, not for hypertension much anymore because we have better antihypertensive agents. And even though, like I said, we have three P2Y12 antiplatelet drugs, clopidogrel, ticagrelor, and prasugrel. And even though there's more consistent response with the newer drugs, prasugrel and ticagrelor, for some reason, clopidogrel is still the most commonly prescribed P2Y12 inhibitor in the US. I think it's because it was the first one, so there's just physicians are just more familiar with the older drugs, and it's been generic longer, so more patients could afford it. So yeah, so even though we have other alternative agents and sometimes better agents, like still millions of people are being prescribed these old drugs. So yeah, like I only covered three examples today. Like another example that has a CPIC guideline is hydralazine. Um, but again, like that one's not really frequently prescribed here because we have way better antihypertensive agents. So I didn't even cover that one. On the FDA list, there's maybe like 10 more cardiovascular drugs. But yeah, so I only picked these three examples based on, like how they're really some of the most commonly still prescribed ones, and the evidence for the pharmacogenetics is the strongest for the examples I covered today.
All right. Thank you, Ma.
Thank you very much. I think at this juncture, I can still see Samuel. Maybe let's take Samuel as the last question, then we see how we can call it a day and allow you to rest. And especially here is getting late. I understand that your one is around afternoon or early morning.
Hello,
So
good evening.
Hi,
yeah,
Samuel.
Yeah, sorry I joined late, but then this is a very interesting session. So a quick one. I just want to know, are there instrument and equipment in Nigeria that can be used to carry out this testing to know either one is a poor metabolizer or for these drugs?
We don't know now. Is it not from the US?
I
But
I
family,
don't I don't know what's available. I
I don't know.
know through
I
the PGRN, the Pharmacogenomics Research Network, there's like collaborative research studies. And I can't remember if it's Nigeria or other countries in Africa where they're doing some of the genetic testing for cancer drugs. Um, so I assume like the genetic testing capability is there and available in labs. In the US, like your lab test, in order to use any kind of new lab testing to make clinical decisions, it has to have special certification called CLIA. So I assume there's probably a similar like clinical certification that's required for any kind of new lab testing in Nigeria too, but I'm actually not aware of what is available there. I don't know if anybody else might know better than me on the Zoom.
thank you very much, Dr. Jasmine. At this juncture, I wish to specially thank you. And in fact, I would like to invite the chairperson of the Clinical Pharmacists Association of Nigeria for a short vote of thanks. Please, Dr. Maureen, I can see she's around.
Good evening, everyone, and good afternoon to our dear presenter. I'm overjoyed this evening. So, I want to start by expressing our gratitude to our dear presenter, Dr. Jasmine, for bringing out your time to speak to us this evening. Thank you so much. We appreciate your time. I want also to thank our dear Dr. Nuruddin Usman for making sure that we get you to do this presentation. Especially, I want to also thank the text officer one of the cardiology group of my Stephen, Dr. Maureen. Thank you so much. Yes, at least we can hear Cardiology Pharmacists of Nigeria now. I want people to continue, don't relent, continue to push harder, and continue to educate us on this your specialty group. This topic she treated today is art. Wow, this is my first time. I do hear about pharmacogenetics, but at least today she really narrowed it down to cardiology. Okay, we used to dispense metoprolol, clopidogrel, statin, but I never know that outside the looking at the patient's renal impairment, liver disease, all those nitty that we all look out at clinical pharmacy. I think I know something that is still missing, which we are not doing. That is checking our patient's pharmacogenetic makeup, which will help us to really give our patients personalized medicine. I pray that soon we will get there. Though I know Nigeria, we're in a low income setting. Most of the time, our patients could not even afford to do small ABG tests, even the serum questionnaire results. They find it difficult to pay for those little tests they say as per the cost. Talk less of this macrogenetic but we hope to move up to this level. The most important thing is there will be options. If you are willing to pay, the test will be done so that the clinical pharmacists will optimize the patient's medication. And it is now left for us here in Nigeria to aspire to become a pharmacogenetic clinical pharmacist. So it's not another specialty, which some of us will try to look into. Okay, during the course of this presentation, I saw so many of our prominent pharmacists on this call. Our dear Dr. Issa, Dr. Timi, Dr. Rita, Dr. Solomon, Dr. Luatoyin, Dr. Bello, Dr. Andrew Momo, Dr. Biajoro, and some other prominent pharmacists here, which I may not mention now. We are grateful, ma. We hope to have you once again. Please, you just expose 3 medications. Please, next time we want you to go into more other medications to really explain what we should do at clinical pharmacy. Once again, thank you so much and God bless you.
Thank you, everybody, for calling in on your Friday night.
Thank you very much. We appreciate and we hope our link is going to be maintained. We are not going to allow you to rest. When next we come knocking, I hope you are going to accept our invitation. Thank you very much. And I want to specially thank Mohammed Kabir MK, who is one of the PhD students in the University of Michigan, USA, who facilitated the linking of Dr. Jasmine with us. Thank you very much, MK, Mohammed Kabir. Thank you very much. So at this point, I wish to call for a closing prayer so that we can all go and have some rest. Please, I will also invite a volunteer to give us a closing prayer so that we can close for the day.
Let's pray.
Yeah, thank you.
Yeah. I'm one of the participants from Ghana. I joined all the way from Ghana.
Thank you very much. Yeah, you're welcome.
Father, I want to thank you this evening. We are most grateful for this kind of renewed knowledge we've received tonight. We pray that you give us the strength to be able to delve deeper into this topic. So at the end of the day, we'll have the edge to ensure that there is quality improvement in the outcome of our client as we use these medications. And I ask that you will strengthen our resource person who spoke tonight, that whenever we had the opportunity to invite her, she will still have adequate information relevant to patient care. We ask this only through Jesus Christ our Lord. Amen.
Thank you very much. So
Amen.
thank you everyone for making this a very, very engaging session. And thank you, Dr. Jasmine, once again. And have a wonderful day ahead. Thank you.
Thank you.
Bye.